Hello everyone, welcome to another video on nursing insights with calebmulonga. Our lesson for today is the pathophysiology of renal failure. So if you've noticed, the past two pathophysiologies that we have put out is for hypertension and CCF, and in these three we can notice the link, the connection between hypertension, CCF, and now renal failure. We are going to see the connection. So stay tuned as we go through and learn together in our lesson. So before we go into the pathophysiology, let's just have an overview of renal failure. So this is the condition in which the kidneys are unable to adequately excrete toxic substances from the body. So in renal failure, the kidneys fail to excrete or remove the toxins from the body. So the major function for the kidneys is to excrete these toxins out of the body. So the causes of renal failure are classified into three. So here we have to also look at the causes because they are cardinal in understanding the pathophysiology. So the three causes of renal failure, one is pre-renal cause, then we also have intrarenal causes, then the other one is the post-renal causes. So the pre-renal causes, this refers to causes outside the kidney that reduce the renal blood flow. So here, what we have to understand about the pre-renal causes is that these are causes outside the kidney that will reduce blood flow coming to the kidney, the renal blood flow. So this is the result of impaired blood flow that leads to hypoperfusion of the kidney, and a decreased renal blood flow decreases the glomerular filtration rate. So here there will be renal perfusion, there will be reduced blood flow going to the kidneys. And then when there's reduced blood flow going to the kidneys, there will be decreased glomerular filtration rate. So what is the glomerular filtration rate? So this is the rate at which the blood is filtered in the Bowman capsule, as we call it, or in the glomerulus. So the glomerulus is where the blood is filtered going into the renal tubules. I hope that's clear. And that all this is happening in the kidney. Then the intrarenal causes, it results from actual damage of the glomeruli or the kidney. So this is as a result of damage, actual damage to the tissues in the kidney or the glomeruli. Acute tubular necrosis is the most common type. So acute tubular necrosis, where some of the tubes, the tubules in the renal system die. Necrosis happens, and then such things happen. Then there is post-renal cause. These arise from an obstruction in the urinary tract, anywhere from the tubules to the urethral meatus. So the intrarenal, these are causes that occur outside the kidney that will reduce blood supply to the kidney. Intrarenal, actual damage to the parenchyma or the tissues of the kidney. Then the post-renal, this occurs due to obstruction in the UT, the urinary tract, anywhere from the tubes to the urethral meatus. So now, having had this background, now we can go into our pathophysiology. So the pathophysiology. So we know that it's either of the three causes. So it's either there's less blood reaching the kidneys, or there's blockage in the urinary tract, or there's damage to the kidney. And these three things, any of the three, will result in reduced blood going to the kidney, which is hypoperfusion. And then when there's reduced renal blood flow, this will decrease the glomerular filtration rate, meaning there will be reduced blood. There will be reduced filtration of this blood in the kidney, in the glomerulus. So this pathophysiology can be grouped into two. There's renal vasoconstriction and there's ischemia. So the first one is renal vasoconstriction. So remember, there's hypoperfusion in the kidney resulting in reduced glomerular filtration rate. So this means that there is hypovolemia. This means that there is hypovolemia, and decreased renal blood flow stimulates renin. So hypovolemia, meaning less blood in the body, will be sensed in this glomerular filtration, in the glomerulus. The glomerulus will sense that there is less blood. So there will be the activation of the renin-angiotensin aldosterone system. So this system now will release renin because there is hypoperfusion. There is hypoperfusion and hypovolemia. So this activates the renin-angiotensin aldosterone system and results in constriction of the peripheral arteries and the renal afferent arteries. So this simply means when this system is released, is activated, there will be constriction of the blood vessels in the kidneys. With decreased renal blood flow, there is decreased capillary pressure and the glomerular filtration rate, as well as the tubular dysfunction, and ends with oliguria. So here what we're saying is there's reduced blood coming to the kidneys. So there will be decreased capillary pressure. There will be reduced blood pressure in these capillaries. What this will result into the glomerular filtration rate reducing, and there will be tubular dysfunction. These tubes are receiving less blood, less nutrients, so there will be tubular dysfunction. And because there's reduced blood being filtered by the glomerulus, there will be oliguria. Oliguria is simply reduced urine output. So now, because of oliguria, which is decreased urine output, there will be accumulation of waste products in the body because these waste products are not being excreted through urine, which is the major way of excretion of these toxins by the kidney. So there will be accumulation of these urea products. So that's about vasoconstriction. And then on ischemia now, the second part is the ischemia. So ischemia alters glomerular epithelial cells and decreases glomerular capillary permeability. This reduces blood flow and leads to tubular dysfunction. So remember, due to vasoconstriction, we have hypoperfusion of the kidneys. So because we have reduced blood going to the kidneys, there will be ischemia. The ischemia will occur to some of these tubes, some of these blood vessels. So ischemia will occur to some of these tissues in the kidney. So because ischemia has now set in these tissues that are receiving less blood, such as the glomerular and the tubules, this will alter the epithelial cells, the cells of the kidneys, and reduce the glomerular permeability. So meaning the amount of blood that is coming into the glomerulus will decrease further, will reduce further. This reduces blood flow and leads to tubular dysfunction. So because of the ischemia that is now altering the blood vessels of the glomerula, there will be reduced, further reduction of the blood being supplied to the glomerulus. The kidney's response is to release renin, an adaptive response to maintain perfusion to the glomerular bed. So because now here there is further reduction of blood being supplied to the glomerula, there will be further release of renin so that there can be more reabsorption of water, more reabsorption of salts, hence so that there will be more fluids in the body and more fluids going to the kidneys. So the renin breaks down angiotensinogen to secrete angiotensin 1. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, a potent vasoconstrictor, which then increases the blood pressure and volume. So here, these are the things that will happen. And remember, on vasoconstriction, I also explained this part. So this will further continue because of the reduced blood that is being received or that is being supplied to the glomerula or the glomerulus. Angiotensin 2 also stimulates the release of aldosterone from the adrenal gland, adrenal cortex, resulting in sodium and fluid retention by the renal tubules and stimulation of ADH. So here we know the functions of the angiotensinogen, angiotensin 1. It will secrete, it will cause vasoconstriction, resulting in increased blood pressure. And then the blood volume will increase due to the retention of fluids due to the stimulation of the release of aldosterone from the adrenal cortex. There will be more retention of fluids and sodium, and then they will also stimulate the ADH, which will further increase the reabsorption of fluids. This response leads to an increase in the extracellular fluid in the body. As a result, there will be pitting edema, pulmonary edema, and hypertension. So, sorry. So this response, where now we have a lot of fluid in the body, this will result in increased extracellular fluid. When there is extracellular fluid, there will be seepage of fluids from blood vessels into the outside, into the tissues. So that is why we see symptoms such as pitting edema in heart failure, pulmonary edema, and hypertension, because there is increased blood pressure due to vasoconstriction, and there is increased blood volume, fluid volume due to sodium retention and fluid retention. So furthermore, due to hypoperfusion, tubules will be damaged, interstitial edema occurs, and necrotic epithelial cells accumulate in the tubules. So there will be hypoperfusion of the tubules. That's what we know. There is hypoperfusion of the tubules. Will be damaged. So there will be tubes. The tubules will be damaged. Then there will be interstitial edema. And then furthermore, there will be necrosis of the epithelial cells of these tubes, which will lead to the accumulation of these dead tissues, these dead cells in the tubes. Then the debris lowers glomerular filtration rate by obstructing the tubes and the tubular fluid flow. So lastly now, these dead tissues will now accumulate in these tubes. They will accumulate in the tubes, they will accumulate in the glomerulus, they will accumulate in the kidney tissue itself, the organ itself, the tissues of the kidney. Hence, that will furthermore decrease the glomerular filtration rate, increasing or worsening the renal failure. So that's the simple pathophysiology of renal failure. And renal failure is classified into acute and chronic. So this is a simple pathophysiology that can cater for the acute one and also the chronic. So we have come to the end of our lesson. Thank you for watching our videos. I hope you enjoyed our lesson. Please subscribe to our YouTube channel at calebmulonga. You can follow me on Facebook, calebmulonga, and would like you to continue liking our videos, sharing and commenting so that we can interact. And for those who are interested in nursing tuitions, we offer tuitions for those who are writing NMCZ exams. So you can contact me on Facebook, Caleb Mlonga, or you can call the number in the comment section. Thank you. See you next time.